Dr. Ozen, we are recording. So first of all, can I just say thank you so much, Dr. Ozen, for giving us your precious time today and answering our questions. I just need to let everybody know that I have the honor of basically asking your questions to Dr. Ozen. Am I allowed to call you the master of genetics, Dr. Ozen?
Oh, thank you. But I have to say that I appreciate your taking your time and letting me explain the issues regarding PGD here. And I feel that you're having me here, actually. Thank you.
What I'll do is I will make sure that we attach your biog underneath this video so people can see all the incredible things that you've done in the world of genetics and genetic testing, because it is truly, truly fascinating to know what you've done. But I know your time is very precious, so I have got a list of questions from readers that I'd love to just start firing at you, if that's okay.
Sure.
Ready?
Sure.
Well, first of all, can we just start by, would you be able to explain to us chromosomes? What do we need to have? What makes the perfect embryo? What do we need in terms of chromosomes?
Maybe before starting what chromosome is, let's start with the DNA.
Yeah.
So in our cells, we have a DNA. We have DNA molecules, 46 pieces. It's like a bowl of having 46 pieces, which is mixed and combined like this. But when cells start dividing, they are replicating and shrinking. So in dividing cells, we call this DNA as chromosomes. So each of us have 46 chromosomes. Half of them from our mother, half of them from our father. So 23 from mother and 23 from father. And 22 of them are the same. Number 1, 1, 2, 2 goes till 22nd. What about the 23rd ones? Females have 2 X chromosomes and males have 1 X and 1 Y. So Y defines that the embryo will be male or not. So we have 22 pairs of chromosomes, molecules, DNA molecules, and in addition to them, which is 44, 1X and 1X for females, 1X and 1Y for males. This is chromosomes. So we have all our genetic information in these chromosomes. And when cells divide, even in regular cells like in our skin or liver, they divide, and then the same chromosome numbers are replicating, and at the end we have same amount of chromosomes at the end state. But for gametogenesis, cells in gametes, such as sperm or oocyte, we have to divide the chromosomes in half. Otherwise, if we give 46 chromosomes for each ancestor or each child, so numbers will get higher and higher. So we are dividing the number of the chromosomes to 23. So from sperm, we have 23 chromosomes. From oocyte, we have 23 chromosomes. And in total, it makes 46. So from the sperm, if X chromosome is coming, the embryo will be female. And if the sperm is carrying a Y chromosome, then it's going to be a male embryo. So if everything goes smooth and the way it is supposed to be in nature, okay, we have 46 chromosomes. But sometimes, as we mentioned before, we're dividing them into half. One is not going and the other one is staying behind. But if we give more chromosomes, instead of staying behind, if the ones coming together, let's say in trisomy 21, which is called Down syndrome, well, from female or male, which means from oocyte or sperm, there is one extra 21st chromosome is coming. So we have, instead of 46 chromosomes, we have 47 chromosomes. Here in Down syndrome, we have 3 21st chromosomes. So this is chromosomal numerical number problems we have in genetics. We call them as chromosomal numerical abnormalities. For females in oocytes, in time when women are having older ages, we usually define it as 35 years of age, but some people say 38 years of age. All sides are getting aging. So here, this separation of the chromosomes somehow getting trouble. Mm-hmm. So the possibility of this kind of a numerical problem is getting higher when the woman age is going higher, especially after 35 years of age. So here, when we have a couple where the woman is 35 years of age, so we have to be careful that there is a possibility, there is a little bit higher risk for chromosomally numerical abnormal embryo we can encounter in IVF embryos.
Can I just ask a question? And so for men, it's just women who, as they get older, they will potentially experience problems. It's not, the guys don't have an issue. Is that right?
Yeah, they do. No. Mainly in women, because we have our oocytes sitting in the ovaries and being fed by the attaching cells there, but males are producing it all the time. So production of the gamete cells in male and female is different. So in age, those oocytes are getting aged. That's what we have concerned about, the chromosomal segregation problems with age. But of course, this kind of problem for chromosomal abnormality disorders can be caused by a sperm source as well, but it's mainly from females.
It's so frustrating because as women, we're just, when we get into our sort of 30s, mid to late 30s, that's when we're kind of like ready, when our careers are established, and then it's like,
You're absolutely right. You're absolutely right.
It's so frustrating. Is there, sorry if this is a naive question, but is it possible to test, to do a test before you even start the IVF process to see how good your genetics are? Is that possible? Is that a thing?
In some terms, yes. It's something like that. When we call chromosomal abnormalities in numerical manner, I mean, there is no way we can address this oocyte will give an extra chromosome or not. We cannot know that. But in some conditions, there are some translocation carriers. It can be male or female. So this 21st chromosome can be attached to a 13th one. So when 13 goes, it goes an extra 21st chromosome. So with this kind of translocation carriers in male or female, it's good to know before going to IVF procedure and procedure. Or sometimes we have not just head-to-head chromosome numerical problems, but sometimes chromosomes are sharing their arms. So we have translocated, like let's say, hybrid chromosomes. So this is also a problem. So it's good to have a cytogenetic manner, I mean, a genetic analysis before going IVF, especially after successive IVF failures or miscarriages. It is better to...
Sorry to interrupt you. I was going to say, how do you have those tests?
Oh, it's a very simple genetic test from the blood. It takes nearly maybe 10 days that you can easily figure it out if one of the parents is a carrier of this kind of a translocation or not. And it's a very cheap one, I have to say. Again, saying that successive miscarriages, IVF failures can be caused because of this kind of a translocation carrier in one of parents. They should do that.
And because we get this question a lot, there are so many frustrated people because they have an IVF cycle and it fails, and then after that their doctors say, well, let's try for this and let's test for that. And a lot of people have said, well, why couldn't we have had that test to start with? Is this a test that you are saying you would only do after a failed cycle? Or if a patient came to you and said, look, can you just do it before I start? Is that an option?
Yeah. Well, usually, yeah, I understand. Actually, it's a very good question, I have to say. Before going an IVF procedure, is there anything that we can do genetically? If we had such a problem, maybe we should be taking care of with this issue. Yeah, some couples may go for it, but it's usually, I mean, for the doctors, when they request cytogenetic analysis, they usually wait for miscarriages or other IVF failures, but it's a very cheap procedure and doesn't take too long. Well, I guess it's up to the patients right now to decide whether to do it or not. But from doctor's point of view, it's only recommended when we have clinical problems. But who knows who has it, right? Yeah. So as a couple, people can go for it. And not only for chromosomal abnormalities, but also for single gene disorders. That's another issue.
What is that?
What we mentioned here till now is chromosomal numerical or structural problems. But in the chromosomes, we have many genes. We call them single genes. Let's say cystic fibrosis gene, or Fragile X syndrome gene, or spinal muscular atrophy gene. These are single gene disorders. These are the genes in the chromosomes. So we might have a mutation, a pathogenic mutation, which means this mutation will cause a disease. In some of them, you are only a carrier, which means both copies has to be mutated for this kind of a disease to have a clinically affected person. Sometimes one mutation is enough, so we call them as dominant disorders. Usually, one of the parents have the clinic as well. And some of them are X-linked disorders that the females are carriers. They have, remember, 2 X chromosomes. They are carriers, but when they give it to a male fetus, so it's going to be affected. Let's say Duchenne muscular dystrophy, or Fragile X syndrome, or hemophilia. Here, I have no family history. Let's say we have a couple, and having no family history of any genetic disorder. May I be a carrier of a genetic disorder? May I have one gene which is mutated, pathogenic mutation it has, and maybe my spouse has the same gene mutated with a different mutation? Well, right now there are some tests which is designed as panels testing for the genes which are commonly seen in the population. So for these genes being tested, let's say that I am found to be a carrier of this mutation, and what about my wife? Is a carrier? Or if they are both carriers, then I should go for PGD. Preimplantation genetic diagnosis, not having a affected baby with the chance of 1/4. Yes. Because when I'm carrier and my spouse is also carrier, so we can give the mutated gene, but My wife can give normal one, so it's going to be a carrier. In order to be an affected child, both has to be mutated. It's going to be 1/4 chance. So there are things that couples can do for chromosomal disorders, like cytogenetic testing, and for single gene disorders, for this single gene panels being tested. But there is another issue here, especially for consanguinity marriages. The risk for being a carrier for a single gene mutation is getting higher when we have consanguinity marriages, because a mutation is happening here and being carried out through the generations and maybe first cousins or something like this. So here, especially if they are having a family history for consanguinity marriage, I strongly recommend that. And yeah, we are having couples that are just tested and found to be a mutation, found to have a mutation in the same gene with no family history, with no consanguinity marriages.
So what do you do for that couple? How did that couple then go forward to have a family? What do you do? How do you guide them?
Well, then we are not, of course, requesting everyone on the street who's planning to marry or planning to have a baby, or go and do some genetic testing. But right now we are in the era that there is a chance, or there is say an opportunity to have this test. Why not doing it? Let's say you are a carrier of a cystic fibrosis gene. Okay, in Northern Europe or in America, the cystic fibrosis carrier state is higher than the Mediterranean places. If you are from a Mediterranean area, beta thalassemia carrier status is higher compared to the other. So it's really better to be tested, especially for commonly seen disorders, whether you are a carrier or not.
And so going back to the testing, if a couple are experiencing multiple miscarriage or implantation failure, is this when you would recommend PGS testing or PGD testing?
Yes. So,
and is it because there's an imbalance in those chromosomes, as you were saying?
Sure. As we mentioned before, chromosomal abnormality seen in fetuses, the risk, is getting higher with age, with successive IVF failures or miscarriages. So let's say that we have no information about the aborted embryo, because here abortion material is a very precious material, should be checked for cytogenetically at least, or with array CGH, which is small deletions or duplications testing, which is should be done. So learning that this fetus has this kind of a problem, so we should be more careful about in IVF procedures, because what we mentioned till now was carriers. Male is a carrier, female is a carrier, or aging problem or something like that. But there is a mosaicism in our body. Sometimes in our body we don't carry this mutation. In blood level we are normal. But in sperm and oocytes we are producing new mutations. And males are producing more sperms, so which means they will produce more new mutations, which we call de novo mutations. But for female, not,
what was it?
But now you will be happy with this, because oocytes are not dividing, or we are not producing oocytes all the time, right? We have a number of oocytes already make it work. So then, having new de novo single gene mutations in oocyte compared to the sperm is very less. So sperm production is an ongoing thing. So the new cells are being produced all the time. So the chance of having a new mutated gene, one of the genes, I mean, is getting higher. So with age man, let's say, we have more chance of accumulating maybe this kind of mutated sperm collection, let's say. So what we have here now, in blood level, we are normal. But in our gametes, we have a collection of newly produced sperms or oocytes carrying a mutation. So here, let's say that we have a baby with this dominant disorder. We can say that it happened only for one time, and it's not going to be repeated. This should be taken into consideration by the clinicians very carefully, that even in gametes, we might have mosaicism. Even our testicles or in ovaries, we might have mosaicism. Some sperms may be normal, but we might have a collection of sperms which is producing this mutation. In dominant diseases, we shouldn't only say that, oh, dominant diseases with this dysmorphic features will not be repeated. But one of the parents might have a collection of this mutated gene carrying in sperm or oocyte, so it can be repeated. We usually call it as sporadic cases. Happened in one sperm and will not be repeated. But sometimes there might be a collection of sperms in the testicles or collection of oocytes in the ovaries that this can be repeated. Cannot guarantee that.
Can I ask, if you do decide as a patient to have your embryos tested, is there any risk involved?
Risk in doing the procedure, you mean, or doing the test?
In terms of, could you potentially be damaging the embryo if you're doing a PGA testing?
Maybe we should start from the beginning, how we collect oocytes and everything. So when we give hormones, the purpose is to let the lady produce more oocytes, right? So we are having many oocytes compared to the age when we have younger ages, more oocytes. And we have higher ages, number of the oocytes we are able to collect is getting less. Well, let's say that, let's do the number scenario. We have 10 oocytes collected. We call it as OPU, oocyte pickup, OPU. And this is day 0. When we collect 10 oocytes, at the same day, we fertilize them with the sperm under the microscope. We call it as intrahepatic sperm injection. And the next day, which is day 1, we check the embryos if they are fertilized or not. Let's say one is not fertilized. So now we have 10 oocytes. Now we have 9 fertilized ones. And still here, the embryo is using the energy, or all metabolic things is going with the oocyte potential. What comes with the oocyte till day 3. The genes are not getting that activated, so it's using its sources, some source. So in day 1, it's 1 cell. Now it starts dividing, 2 cells, 4 cells, and in day 3, it's 6 to 8 cells. We take 1 cell out, which is called blastomere analysis. See, we had 6 blastomeres, and we got 1 out. Or we didn't do it, we just waited. But in day 3, remember, we had 9 fertilized embryos, 1 did not develop. And in day 3, we have only 8. Okay, let's continue. Now there are more cells divisions, and we call it as a morula stage in day 4, more compact manner. And in day 6, a liquid is starting accumulating in it. We call it as a cyst. So it's called a blastocyst stage. Here we have one inner cell mass, and surrounding cells will produce the placenta, the chorionic cells. So here, from chorionic cells in day 5, we take 3 to 5 cells, sometimes 6 cells biopsy. Here, what we did in day 3, we took 1 cell out of 6 or 8, but in day 5, here, in the cell mass, here, the fetus will develop, but from placenta, we took the cells. This is less damaging for the embryo. In time, we did lots of blastomere cells. This is how we started PGD. We were using blastomere cells for preimplantation genetic diagnosis. Now we see that it is more vulnerable in day 3 compared to day 5. So if you ask a question like, are we giving harm to the embryo? Now, with this technology in day 5, blastocyst biopsy from trophectoderm cells, they are giving less harm to the embryo. But we freeze them. Okay. We freeze them and we test the embryo with the biopsied cells and decide by using some technologies remember we had 24 chromosomes. We check if there is a gain or loss in 24 chromosomes in one of them. Or single gene disorders. We could do in blastomeres and also in blastocyst stage. We usually, right now, we cannot, the technology doesn't allow us in day 3 embryos, which is not that analytically validated, for 24 chromosome testing. It's 5 or 7 chromosome testing with successive fish technology hybridizations. It's more technical.
Can I also just ask, what sorts of, because actually one of the questions here was like, what sorts of people would you advise to have PGS testing? If you're under 35, for example, and you've had a failed round of IVF, sadly, would you, if the embryo didn't implant, would you test the embryo of a woman who was under 35?
Well, we see chromosomal abnormal fetuses even in younger ages. So we cannot just say no, but what we can recommend that if, let's say, the woman has 35 years of age, should I recommend her to do the testing? Well, let's say that we had 3 embryos developed till day 5. Or we had 15 embryos developed in day 5. So we have more chances here. We have less chances here. So finding and also analytical validation of the 24 chromosome testing is a little bit problematic compared to the fish analysis, I have to say. So in 3 embryos, we find some mosaic level problems, and some people are unnecessarily discarding those embryos, and those embryos are not being used for embryo transfer. Now there is a debate that are we giving harm in clinical level by just diagnosing these embryos and then discarding them. Maybe we should discuss this mosaic pattern here in embryos.
That's one of our questions, actually, yeah.
Yeah, it's a little bit related with that. So when we find chromosomal abnormality in 24 chromosomes, let's say for number 13, by the way, number 13, 18, and 21, abnormalities in trisomy level are, we can see them as live birth. We don't see live birth trisomy 10 or 12, something like that. Usually 13, 18, and 21 is important here. And let's give another example like chromosome number 11. We found in this embryo, not at trisomy level, but close to the trisomy level. It's somehow giving us an idea that, remember, we were collecting we were biopsying 45 cells from there. Some of them were abnormal, some of them were normal. So it didn't go that trisomy level, but here is between the normal and trisomy. So we call them as mosaic pattern. But what about this mosaic pattern in trophectoderm cells? Do we have it also in the inner cell mass? We don't know that. It's a possibility. But does it give us an IVF failure problem? Will it implant the uterus or will it go an abortion? Yeah, trisomies and monosomies have this kind of might cause this kind of a problem. We prefer to give euploid, normal chromosome number embryos. But here, there are sometimes mosaicism, like here we have normal, but inner cell mass is abnormal. This is also a possibility. So this diagnosis will not reflect the embryo all the time. Or this was abnormal and embryo was normal. We call in embryo mosaicism. So when we hear mosaicism, it can be between the cells here or between the trophectoderm cells and the inner cell mass. So we discuss it with the patients and we explain it. And we must give a very, very detailed genetic counseling before embryo transfer with the results of preimplantation genetic screening. This is screening. There is no disease. We are screening in chromosomal levels. But if there is a genetic problem, then we are diagnosing it. This is called preimplantation genetic diagnosis. So we are especially looking for a specific condition, genetic condition, creating a clinical problem. So this is diagnosis, preimplantation genetic diagnosis. For screening, preimplantation genetic screening, we are screening all chromosomes, whether do we have a monosomy or trisomy. Monosomy means there is only one copy. Usually, normally, we have 2 copies, or we have 3 copies, something like that.
Science is such an incredible thing, isn't it? It's
joyful, and we have to be very careful while explaining it to our patients. It's not what we talk, which is important. It's important what they understand.
Yeah. Yes.
So you can give talks, but what is important is the level that they understand.
Yes.
So you have to make sure that they understand it. So you need to explain it again and again and make sure that people really understand it and decide together with you.
Yes.
That's important.
I just got to, actually a lot of the questions that we were sent, we have got through, but there's one here. What happens if you do a round of IVF and you have you have your embryos tested, genetically tested? If they all come out as abnormal, as a patient, what do you do? Do you have a fresh? Do you go for another round of IVF? What are the chances that actually another round will you have the same result, or what do you do? Yeah,
let's say that the couple had 4 embryos, and all embryos turned out to be abnormal in chromosomal levels. It doesn't mean that in the next cycle all of them will be abnormal again. Well, there is always a chance to have a normal embryo in each IVF cycle. So I have couples in maybe in 8 IVF cycle happen to have a normal one and then had the baby in their hands. Yeah. So it's a little bit more psychological persistence you give yourself, and be determined with the procedure going on, because I understand, we know that it's a physical pressure, especially for women, but more than that, it's psychological.
Yeah.
People are getting, what is going on? Will it be? Shall I get pregnant? What about the results? Or the results? The doctor is explaining many genetic things, and I'm not understanding that well. Yeah, okay, we understood that part, but what is going on? What kind of a procedure we're going through? We don't know. So, patient together with you, you have to explain it very well. And if the psychological level, if the patient and the couple is going, especially for women, go down, it affects the physiological level as well.
Yes. Yeah.
So I'm always recommending my patients, try to find something else. Okay, we're going things, but get your mind busy with other stuff. But people, when what I mean by other stuff, okay, don't do what you used to do. Do other things. Because when you do other things, or other works, or other meal, or visiting places, you name it, so you will be busy with that.
Yes.
So when you wake up or sleep, if you do the same things, it's coming in your mind, always eating you inside. So this is not good. Yeah. In my center in time, I had yoga lessons downstairs, and couples were coming together, and they were healing each other.
Yeah, that's lovely. Yeah. I had, in the end, I had ICSI, I had IUIs, and I had IVF, and I had ICSI. And it wasn't until my final round of ICSI that I started to get my head around what was actually happening. And and somebody recommended that I should try acupuncture, just to take me out of my house, to take me away, a bit of me.
Exactly. That's very, very important.
Yeah.
And very important, very crucial thing, actually.
Yeah.
It's not just biological thing going on. Psychology is affecting physiology a lot. Yeah. That's important.
Yeah. I just, before we end, I just need to run my eyes down here to make sure you've done that one and that one. Crikey, we've got through a lot. Yeah, we did this. This is a question. I have had 2 failed rounds of IVF, both ended in miscarriage. I'm scared to have another round of IVF in case I miscarry. Should I go for PGS? Do you think my embryos are faulty and causing my miscarriages? Shall I ask for this test? You have answered this in your talk, but
actually it's not only genetics what is going as a problem here. Obstetrician, IVF doctors should examine her in other, like immunological problems or some other things. So it's not only genetics affecting IVF success, but other issues we have. So IVF doctors and geneticists work together. And so it's not, I mean, I'm repeating maybe again, it's not only genetics, but other issues we might have should be examined by IVF doctor. We'll continue doing the IVF procedure. I told you, this is the persistence. You know? I have a couple in 12th IVF cycle, they got their baby. Imagine 12. Right. I'm not sure if I could go myself.
No.
The 12th cycle, but he was an obstetrician. He was an obstetrician, and then the couple was, and they went through it. Yeah. And the 12th cycle, they got their baby. I'm not saying that go through all the time, but well.
Yeah. Well, sadly though, money is also a massive barrier for so many. But yeah. One thing that you said in there that has given, a huge element of light is that, just because you said if you have a round of IVF and all your embryos are abnormal, it doesn't mean that there isn't a chance that you are going to have a healthy birth, which is a wonderful thing. Because talking from my own experience, when you fail a round of IVF, hope just go.
Sure.
Just goes, and you just have this heavy dark cloud over you, and so to hear you say things like that, it's hugely encouraging.
And we shouldn't be just seen as selling hope. Right? This is reality. We have this.
Yeah.
And it's a fact that we have couples at the end having these babies. If you want to see this part of the procedures, so you can go down. Or if you see this part of the procedures, you can go high. So it's hard for patients to decide. But we understand that, and we're trying to help them to give examples and do the right thing for them to do. Yeah.
So just to sort of to wrap up our conversation, would you say that for a couple that are about to go through a round of IVF, would you say don't get too caught up on having all these tests? First of all, trust in your doctor, and so have your IVF, and then perhaps have further testing afterwards if sadly your round hasn't succeeded.
Sure. IVF doctors should examine her from top to the bottom, and all hormone levels or other anatomical levels, immunological levels, and also with the genetic levels and with the family history they have. Yeah. So all of them are important for IVF society, let's say, doctors, geneticists, laboratories, and everything. So each couple has its own structure. You can't just follow this the way it is, or we're gonna have the, oh, now everyone is doing and having their baby now. No, yours maybe from this level, or yours from the other thing. So this is how it is.
Okay.
Yeah.
Thank you so much for your time today.
Thanks for you having me here.
Maybe I could borrow you again for another hour, another day, and ask you the question.
Yeah, I would be pleased to do. Yeah, sure. Of course, all the time, whenever you want.
Thank you so much. And for any other questions, I will just tell people to perhaps just drop IVF Turkey a line. Maybe they could get in touch with you via that way.
Yeah, I would love to answer them.
Yes. Dr. Ozen, thank you so very much.
Thank you, Ms. Jacob.